Tushar, start. Tushar, শুরু করে দাও।
Sir, should we start now?
Yeah.
Okay. Thank you, sir. Honorable and respected panelists, and my dear participants, Assalamu alaikum. Today is our second session of lectures in the ECG study group. We're starting with the basic things of the ECG. Today, Professor Abdul Badur Chaudhary, sir, will tell us a little bit from the history, measurement, calibration, and lead system of ECG. So I request Professor Abdul Badur Chaudhary, sir, to start his session.
Assalamu alaikum and good evening, everybody. Today, I'm going to talk about the fundamentals of ECG. This is the second lecture we are giving. And actually, I'm a little bit afraid because there are so many elite persons are there. And they are so much, very much knowledgeable about all these things. Still, I'm going to go through the fundamentals, the history of ECG, about the machine, paper, calibration, and leads. We know that the heart is an electrical organ. Its activity can be measured non-invasively, and ECG is nothing but the graphical representation
Sir,
of the...
share your screen, sir.
Oh, sorry. Wait just a minute. Yes. Ayaz. I think I have to go through.
Just share your screen. Just share your screen.
Ayaz, quick! Ayaz! Ayaz!
মাদুদ চলে
এই
গেছে
ডাকতে গেছে ইসে
নিচে ও দেখলেই তো পায় নিচে শেয়ার স্ক্রিন একটা গ্রিন বাটন আছে
সালাম স্যার সাবুদ্দিন স্যার জামিল স্যার সালাম স্যার
হ্যাঁ গোবিন্দ হাউ আর ইউ
লাইভ
স্যার মহসিন স্যার আসসালামু আলাইকুম স্যার রফিক স্যার
ওয়ালাইকুম আসসালাম
গোবিন্দ স্যার আমি গোবিন্দ
লাইভ চলতেছে
Govinda, you are on Facebook Live.
Internet nai. Try. I don't know how you're doing it. There is no internet. কথা বলার চেষ্টা করো. You're unmuted. You're unmuted.
I'm not muted.
No, muted now.
How you screen?
Share them.
হ্যাঁ, আমি ইয়ে হয়ে গেছিল, আবার সব নিয়েতে ঝামেলা লেগে গেছিল।
ঠিক আছে? Okay.
Acho, abar double click.
Yeah.
Okay.
Sorry, I had a very big glitch, and my son helped me to get out of it. So we are talking about the fundamentals, the history, machine, paper, calibration, and leads. And we know that the heart is an electrical organ, and ECG is the graphical representation of the summated electrical activity of the heart. How does it come into being? The first human ECG was recorded by Waller in 1887 with Littmann's capillary electrometer, but that only revealed two deflections. He termed them V1, V2, indicating ventricular activity. Later, Einthoven, the celebrated Einthoven, recorded four deflections with a refined electrometer, Littmann's electrometer, and he initially labeled them as ABCD. He corrected them somewhat and chose PQRST instead of ABCD. And from then on, the waves come into known as instead of ABCD as PQRST. Einthoven started using the string galvanometer, and he also identified the U wave. This is William Einthoven. He's a Dutch doctor and a physiologist. And he invented the first practical electrocardiogram, and he got the Nobel Prize in medicine in 1924. That was a very cumbersome machine. Look at the person who is putting one leg in a saline pot. Now the newer ECG machine, these are compact electronic systems that also include computerized interpretation. Now what we record? When we record the action potential, we consider that the electrical activity of individual cardiac muscle, when they are summated, those summations are represented as the ECG. When from the inside, the electrophysiology recorded, we call it EGM, electrogram. And when we record it from the surface, we call it 12-lead surface ECG or EKG. Now, as in the first lecture in our series, Professor Adarali already described what is the role of ECG in detection of all sorts of arrhythmia. It is the fundamental. Also, in detecting infarction or myocardial ischemia, we have to go to ECG. It also helpful in diagnosing in pericarditis, in different chamber hypertrophies, in certain electrolyte disturbances, also some drug toxicity. And for that, it plays a supportive role. The most important helpful thing about ECG is that it's a very inexpensive, simple, and reproducible tool. But we have to remember, ECG diagnoses are only valid if we place the electrodes in correct anatomical locations, or the wires are attached to the appropriate electrodes. Recording is of good technical quality. So while recording the ECG, one should be sure the cables are properly connected, the surface where the leads are attached is clean and dry, the electrode skin has good contact, and of course, we should enter the patient data in the ECG, either electronically or after recording the ECG, we have to put the patient name, age, and date on the particular date when the ECG is done. It's very important. We know about the lead. We have 10 electrodes, 10 attachments. We place them on the right arm, on the left arm, right leg, left leg. These are the limb electrodes, 4 electrodes. And the precordial electrodes, there are 6 electrodes. And all these, we have total, look at this. We'll lead 1, 2, 3, AVR, AVL, AVF. These are the 6 limb electrodes, and the 6 precordial electrodes record 6 with the 6 leads. The precordial lead placement is very important. Why? The heart is located in a certain position, and we have to have a standard recording, to make a standard recording, we have to place the electrodes always in a certain position. And what is that? For the limb electrodes, it's very easy. Most of the time, there has been some color coding, or in the electrode, it has been written. This is the right arm, there's the left arm, there's the left leg or right leg. So the technician or the nurse or the doctor, if he's careful, they can put the limb electrode very easily. On the chest electrode, we have to be sure we are putting it in the right position. V1, it should be in the fourth intercostal space, just at the right sternal costal junction. V2 on the left side of it. Space. Do not put the V3 earlier than V4. V3 should be only put when V2 and V4 electrode has been placed. It should be in between. The V5 and V6 almost in the same horizontal plane in the anterior axillary line and in the mid axillary line. So that's the proper placement of the electrodes. If we look at a horizontal section, look at what we are recording. The V1 and V2, they're looking at the right ventricle and the septum. V3 and V4, they're looking at the anterior surface and the near the apex. V5 and V6, lateral wall. So it's important how we are looking at. We also do some right-sided chest leads, sometimes put in there, and posterior. The right-sided picture behind below the scapula, on the posterior axillary line, in the same horizontal line, we have put the V5, V6 electrode. We put it in here. How come? After recording the 12 lead, detach the V1, V2, V3, put these three in here. Or after recording the 12 lead, 4, 5, 6, you can detach them and put in here. And that should be on the posterior axillary line, the mid-scapular line, and the posteriorly paraspinal line. If we consider the right to detect the dextrocardia ECG properly done, then V1 and V2 remain the same. From V3 to V6, we put it in the same way on the right side. Here, the V1 become the V2R, and V2 become V2 become V1R, and V1 become V2R. The rest as easily V3R, V4R, V5R, V6R. That's the way. On a skeleton, on the second intercostal space, angle of Lewis, fourth intercostal space, we have to put the ECG, and thereafter we put it on the left side or on the right side as per the intercostal spaces. Now, that's the ECG, normal ECG we always look. It has certain dimensions, and the PQRST, as we know about it, we'll come to know about them a little bit later. And the segments, the PR, the ST segment, QT, we'll come to know that. The P represents the atrial depolarization. The PR segment is the time taken from the electrical activity to come from the SA node and to up to the upper part of the bundle of His. The QRS complex actually represent the ventricular depolarization. The ST segment and part of the T wave represent the ventricular repolarization. The E wave, which is actually after the T wave, also a repolarization. The ST segment represent ventricular repolarization. The PR segment, atrial repolarization, as well as the time needed from travel, the impulse to travel from SA node to AV node. The standard calibration we have in the ECG is that they look at on the left side of any standard ECG, you will get a rectangular box. It marks the standard calibration. 1 millivolt equal to 10 millimeter. So 1 millivolt equal to 10 millimeter, we get that. So 5 millimeter means 0.5 millivolt. What about the horizontal axis? Here, the distance actually represents time, duration. This interval actually represents the time taken from impulse going from one place to the other. Now, there is also a specific time interval. This graph represents specific time intervals. For example, there are big boxes. The 5 big boxes equal to 25 millimeter, and the 25 millimeter per second equal to 5 big box. If we consider 1, 2, 3, 4, 5, from here to n, if we count all the QRS complexes, then that's the number of QRS complexes we are getting in 10 seconds. With 6, we get what the number of the intervals in 1 minute, the heart rate. One big box equal to, the big box means the small big boxes, 0.2 second. One smaller box, the smallest one, is equal to 40 milliseconds. When we do the small ECG analysis, we are recapitulating again. The paper speed is set at 25 millimeter per second. Now, if you want to be sure about the morphology of a particular wave, we can increase the speed. The figures will be spread out, and we may have more idea about what it looks like. But in a standard setting, the paper speed always 25 millimeter per second. Now, look at this. In ECG, time, direction, magnitude. The P wave begins in the SNO, and that starts the atrial depolarization that creates the P wave. The Q wave starts, and that actually represents the ventricular depolarization. The T wave, that means the ventricle is recuperating, is the repolarization. Now, what is the atrial repolarization? Actually, the atrial repolarization wave actually put somewhere within the QRS complex. Because of the QRS complex, we cannot record the actual atrial repolarization wave, but sometimes it may be seen as a depression of the ST segment. So we represent time in second or millisecond, amplitude in millivolt, direction as we describe it, left axis, right axis, that's how. So this is another diagrammatic representation of the electrical activity, starting from SNO, the atrial depolarization, in time interval, the PR segment taken time to pass through the current, pass through the AV node, where it is delayed, and there's a specific cardiac muscle property that allows atria to contract before the ventricle starts contracting, so that the atria can empty their content into the ventricle. Then the AV valve is closed, and the ventricle start contracting, the seminal valves get open, the blood flows into aorta and pulmonary artery. There's a beautiful sequence of events that God has created for us. The ventricular depolarization, look at this. That's the starting of the ventricular contraction and ventricular repolarization. The ventricle is getting ready for another activity. This segment is the diastolic time. And remember that in heart, though it starts working on the 20th day of intraventricular life, the first organ to start activity. And perhaps the last one, with the last breath, we stop. When the heart stops, we are gone. And till then, the heart continues working. And even then, within a cardiac cycle, look at this. For ventricular systole, if we consider the 8 segment, 3 segment is for systole, 5 segment is for diastole. That means heart is getting enough resting time. The diastole is a very important part of the heart's recuperating time. Now, we are seeing by ECG the electrical activity of the heart. So, what surface it is representing? In the ECG machine, it has been arranged in such a way when the electrical current is moving towards a lead. What is a lead? Look at this like this. Lead is like an electrical window through which you are looking at the electrical activity of the heart. So if the current front, electrical front is moving towards you, you will have a positive reflection. If it is directly towards you, the axis of the current wave and the window through which you are looking, if it is parallel, you will have a very high amplitude deflection. But if it is towards you, but at an angle, the amplitude will be less, but it will be still a positive deflection. But when the current is moving away from you, then you will get a negative deflection. Again, the negativity, the amplitude of the negative deflection will depend upon whether it is directly away from you or at an angle away from you. Now, the heart electrical surface we have defined because the arterial system of the heart, they supply specific territories. The anterior surface V1 to V6. Now, this is LAD territory, V1 to V3 particularly, V4, 5, 6. LAD partly going into S6 territory. What about the inferior surface? Mainly look at this RCA supplying through the posterior descending artery, the inferior surface 2, 3 AVF is mainly the domain of right coronary artery. The lateral surface, AVL 1, AVL 5, 6, they're looking at the high lateral part of the heart. These are the part which are supplied by the circumflex VM branches and sometimes also diagonal branches. So the surface of the heart is important in regarding the blood supply of the heart because we are particularly interested to know from the ECG which surface, which artery is affecting the patient so that the patient is having angina or ischemia or infarction. Now, these are the leads we are seeing, 12 leads. The anatomic groups, look at this, 1 AVL 5, 6. They are the lateral wall, they are represented. Now the inferior wall, 2, 3 AVL. We all know it. I'm just recapitulating again. The P1, P2, they are looking at the septum, as we have said. P3, P4, they are looking anterior wall as well. So when P1 to P4, we call it anteroseptal. So that's the way we should look at how the surface, in where the changes are present, we can tell that we have problem in this surface. Now we have a ECG. How am I going to read it? There are certain points I should identify. The first one is identification. Whose ECG actually you are seeing? That's very important. Then when I'm sure I want to look at Mr. X's ECG and the ECG bears the name of Mr. X, all right, I'm happy. And the age also matches, quite all right. And I want the ECG done today, the date matches that day, so I'm happy. Now the standardization, I have to look at the ECG, whether the calibration or the speed is quite all right. Then I start reading the conduction analysis. What is the rhythm? Then what is the heart rate? Perhaps what is the axis? Then we go into the particular waveforms. What the P wave looks like. What about the QRS? Is there something wrong in there? What about the T wave and U wave? And look at also the intervals. The intervals, the PR, the ST segment, and QT intervals, some of them are important regarding time intervals, some of them are important regarding the deviations or changes we find in them. For example, the ST segment, not the duration, whether it is shifted upwards or downwards or it's isolating, that's very important. About the PR interval, is it very short? Is it very long? Is it proper? Or is there no relation between the P and R? That's important. The QT. In this COVID era, we are so much worried whether the patient have long QT. Should I be using azithromycin? If I use favipiravir, is it producing the QT interval prolongation? If that's so, what am I going to do? What about the miscellaneous other abnormalities? Is there a spike in there? Is it a pacing ECG? Is there something wrong with the pacing? I have to look at it. Then, after seeing all this, I have to come into a conclusion. My interpretation of this particular ECG at this time is this. I have to write it. If possible, if I got a previous ECG, I can also compare with that. Sometimes it's very important whether the changes I'm seeing, is it new or is it old? Is there something seriously I should be worried about? Or I should say the patient, well, your ECG always bears the mark of previous MI or previous problem. It is still here. It's not going away and it's not indicating any new changes. I don't think you have any new problem. Always screen the ECG for quality. Always verify the patient's name, registration ID, and date and time. Make sure that voltage is 10 millimeter per millivolt and calibrated. Screen for the quality, correct lead placement, and noise. We'll be talking a little bit about them one by one. Identification is always important. Is it the patient really the patient's ECG? And is it really the current ECG? The calibration, I'm just showing again and again, the calibration. We know that the calibration vertically, one large box is 0.0 millivolt. Our calibration should be that the ECG should be recorded 1 millivolt equal to 10 millimeter deflection, and the speed should be 25 millimeter per second, so that the interface we are looking at has a meaningful appearance to us. Now look at this one. I'll be showing 3 ECGs of the same patient. A young lady came to me with complaint of palpitation. Done the ECG. What am I looking at? This is a rapid rate. We'll be talking about how we calculate the rate. But the standardization, look at this, 2 large boxes. That means 1 millivolt equal to 10 millimeter. Normal standardization. Now I have done the same ECG in half voltage. Look at the calibration. Only 1 millivolt equal to 5 millimeter. Now a patient with such a low voltage ECG with tachycardia will always think, is this patient have pericardial effusion? Isn't it? Is this patient has this type of low voltage ECG with sinus bradycardia? I'll be asking, is this patient have mixed edema? Is this mixed edematous pericardial effusion as well as the heart rate is low? Because pericardial effusion should have associated sinus tachycardia, but it's not there. This bradycardia it could be the pericardial effusion due to hypothyroidism. And in this case, the tachycardia and the small voltage ECG, I could think this is the case of pericardial effusion. But I would have a look at this calibration and say, oh no, I have done wrong. This is not properly done. Now look at this one. This one, double voltage ECG, 1 millivolt equal to 20 millimeter. And why this is important? Look at the P waves. The morphology looks like it's like P pulmonale. So tachycardia with P pulmonale, does the patient have cor pulmonale? Young lady with cor pulmonale, very unusual. What's wrong? Then have a look at the calibration. Well, it's done at a double voltage. So it's done not properly done. So I should be taking care of that. Again, sometimes when the P wave is not well seen, we do this intentionally to have an idea whether the P wave is actually there or not. And having the knowledge that whether I have done it at a double voltage or a normal voltage or a half voltage, that always helps in reaching a proper educated gas. Is the lead placement accurate? And two things can occur. We can inaccurate limb lead placement occur, inaccurate chest lead placement occur. And it's a very commonly encountered problem that left and right arm get transposed, and we get this negatively oriented QRS complex in the first lead, lead 1. And look at the P wave, it's negative. Lead 1 looks at you from the left side, and it's looking at your heart. So that means the current is going from away from the left side towards the right side. But the SA node is located in the right side. The current goes from SA node to the whole of the atria and left it on the left side. There should be a positive wave in lead 1 always, but it's not there. So there is something wrong in here. So this is a wrong lead placement that's commonly seen. And when we want to find out, is it actually right-sided heart, a dextrocardia, or a right-left transposition of the leads? Look at the precordial leads. Here, the R wave is small in V1, gradually increasing size, reaching height, quite high in V6. So the precordial lead suggests the heart is on the left side. The V1, V2, looking at the right side of the heart, smaller R wave, V5, V6, looking at the left ventricle, which has the most muscle mass, recording the greatest amplitude QRS complexes, positive complexes. So the heart is oriented properly. That means the limb leads are not recorded properly. This ECG is a real life scenario. This patient is a COVID patient at present admitted in Dhaka Medical College, quite serious. He's requiring 15 liter oxygen in the non-orbital mask and not maintaining. We are trying to shift him to ICU for high flow nasal cannula. But they sent me to ECG. I said, oh no, they have transposed the leads. Look at the P wave in lead 1. So should I make any report on this? No. I would say that please repeat the ECG. They have done that immediately. And we found out the limb leads, there is just RBB, incomplete RBB, some axial rotation, and otherwise no significant changes except some non-specific ST2F changes that may be due to carditis. Now, this is, look at this. The patient is in ICU, isn't it? He is ventilated. Now, look at the lead placement. Horrible, isn't it? That is in the second intercostal, third intercostal space. That should have been in the fourth. This should have been in here, this one. And this should have been in here, in between. This should have been in here, and that should have been in there. That's the proper lead placement done. How much wrong lead placement was done in here, in ICU, in a reputed hospital. It often happens. We all doctors should be aware of this fact, and they should take care the technical, the technicians and the nurses. They should be taught how to put the leads properly, because that can lead to wrong information coming to you through the ECG. Now, look at this one. This is another thing. Here, look at V1, V2, V3. We know that the R wave should get bigger from V1 to V6. We have seen that in the previous ECG. Here, V1 is much bigger than V2 or V3. What happened actually? V1 lead was placed into V3 position, V3 lead placed into V1 position. Now it's properly done, same patient. Now it looks quite nice. So you may get some ECG where the R wave is not logical. If it's not logical, always think that could it be some abnormal lead placement? There are many types of errors. We'll have further lecture on that. Today, I'm just getting a little bit of overview of everything. Now, the heart rate. I have seen that the ECG is quite fit for my viewing. The calibration, the speed, the identification, everything is done properly. So I have to uh, count the heart rate. How to calculate the heart rate? We know these things. That heart rate 1500 small square by R interval is small square, or heart rate 300 by R interval large square, or for a irregular rhythm, number of hours in 10 seconds multiplied by 6. This one is the lowest one, irregular rhythm. This is also true for regular rhythm as well. If you have ECG, just record a rhythm step at the bottom. The standard paper record 10-second ECG. So if you are in doubt, count all the hour waves in the 10 second, multiply it by 6, you get the heart rate, either irregular or regular. So look at this one. You cannot count that like that because there is no rhythm step in here. But still, we can count like what? 300 divided by number of large squares. Look at this one. The lead 2, consider 1, 2, 3, 4, 4.5. 300, 100, then we have to divide it by 4, 75, then less. It's around 70. If it's 70 or 72, does it matter? We are nearly the heart rate, or nearly accurate heart rate. Now look at this one. The bottom one, consider all the QS complexes. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. 14 into 6. And that's the heart rate. 84 per minute. The rhythm is irregular, still it doesn't matter. I can count the heart rate easily. And we can always remember this. One big square between the two RR waves, the rate is 300. Two large square between the RR interval is 150. Three large square, the rate is 100. Four large square, rate is 75. Five large square is 60. Six large square is 50. Seven large square gets scared because it's 45. If it's more than that, I have to consider it very repeatedly what to do. So this memorization easily can be done, and we can easily apply it. For in between the large boxes, we can say it's between 150, 160 to 170. We can say it's around 80. We can say it's around 65 or 70. It doesn't matter, a little bit different, but we can say what is the heart rate almost correctly. Now, the rhythm. Whenever we are stating the rhythm, we should always see what is the basic rhythm. Is it in sinus rhythm, or is it in atrial fibrillation, or any other specific rhythm? And we have any other abnormality, we can additional rhythm events if it is there, like a PVC or PSC. We should always say that. Consider all rhythm events from atria, AV junction, and ventricles. What do you mean by that? Now look at this beautiful ECG. Look at the lead 1. There is a P, QRS, T. P, QRS, T. So all the QRSs are preceded by a P wave, and the P wave is upright in lead 1, 2. So this is a normal sinus rhythm. And in AVR, it should be negative, because look at the AVR. It's looking at the heart from the right shoulder. The current from SA node to AV node, and then going down across the interventricular septum to the apex, then coming up, back up. All this is going away from the AVR. It's looking at the interventricular cavity, interatrial cavity. So all the waves should be going away from it. And we are seeing here a negative complex like P, negative P wave, a negative QRS complex. That's the normal thing we expect, and we are getting that. Now look at this ECG. It looks the heart rate 1, 2, 3, 4, 5, 6. 300 by 6, it 50. There's bradycardia. There is P before a QS complex, P before a QS complex. So it is a basic sinus rhythm, but It's bradycardia. Is there something else? Look at the lead 2 rhythm. P, Q, R, S, T. Then what is that? Is it a P wave or an E wave? Any wave in here after T would be either U or P. Now, this looks like the distance from this P to this P and this wave to this one look almost regular. So this could be 2:1 every block, is it? Now look at this one. Here, I have taken from there and magnified it. P wave, QRS, T, then another wave. Nothing in here. P wave, QRS, T, another wave that looks like the original sinus P wave, but it is not followed by a QRS complex. So there is a total blockade at the FE junction after the second P wave. So it's a 2:1 FE block. We can corroborate with the V1. Look at this. V1, negative P wave, RSR pattern, negative T wave, then the negative wave. Looks like the sinus P wave in like that. So it's actually a 2:1 FE block. The bradycardia is due to that. Now here, look at the rhythm history. The QRS complexes, why do we say heart rate? We actually mean ventricular rate. And here, the ventricular rate is slow. So it's saying here 29. That means heart rate is around 29 beats per minute. But why is that? Now look at this small waves, regular small waves coming at regular interval, but that doesn't seem to have any relationship with the QRS complexes. So the ventricle is going on its own. The P waves are going on their own. There's total dissociation, total disharmony, and the QRS complex is a little bit wideish. So there is an escape rhythm, and the rate is around 30. So this is a complete heart block. The rhythm is a complete heart block. Bradycardia is due to that. This is a very chaotic rhythm. So is it atrial fibrillation? Is it something else? Now look at lead 1. Start from the lead 1. Two big complexes followed by two smallish complexes, narrower. Now the second complex seems to be preceded by a quite normal looking P wave. Let's go to the lead 2. The P wave here corresponds to the P wave in there. So this patient must have sinus rhythm and something else. A big complex is like that, interspersed with normal complex. That could be ventricular complex. So the ventricular complex is coming here in a couplet, in a singlet, in a couplet, again in a regular rhythm here. Here 1, 2, 3, 4. There is a non-sustained VT. So the patient is actually having a non-sustained ventricular tachycardia. Because of the presence of the P wave and the QRS, normal looking QRS complexes that is following a P wave, help us to identify the abnormal beat, the chaotic beat we are seeing is actually due to multiple episodes of ventricular rhythm. Now, what is an axis? Axis is the overall measured direction of the electrical activity of the heart. And so axis means direction. Normal axis lies between the 0 degree and 90 degree. By convention, 0 degree is towards the lead 1. 90 degree is towards AVF. And the lead 1, 2, 3. The lead 2 is, the distance between lead 1 and 2 is 60 degree. And between lead 2 and 3 is another 60 degree. The AVF, AVR, and AVL, they dissect the heart in such a way that all this hexaaxial system divides the heart into 30-degree sections. And the wave that is oriented towards that particular lead will produce the greatest magnitude deflection, either positive or negative, and the heart main electrical vector should be lying according to that lead. So if I get a largest R wave in lead 1, the axis of the electrical activity of the heart should be parallel to the lead 1 or towards the lead 1. If the largest wave in lead 3, then the heart electrical activity is rotated towards the right, and there is towards the right side and inferiorly. If we get a largest deflection in FER, positive reflection, that we can get sometimes in ventricular rhythm or many other things, or certain type of arrhythmia, then the axis is towards the FER, a no man's land region. Normal axis between 0 to 90 degree, definitely normal. We also consider up to minus 30 degree. This is 0 degree, this is plus 90, this is plus 180. And if we go upwards towards the AVL from lead 1, there's minus 90 degree, minus 180 degree. So between AVL to 110, minus 30 to 110, we can consider up to that much normal heart axis. Between 0 to 9, definitely. Between minus 30 to 110, sometimes maybe, but it is still normal. Beyond that, it's not normal. Now, how do we determine axis? We can take only two leads, two right angle leads. Let's consider lead 1 and FEF. If we have a QS complex in lead 1, QS complex net result is a positive QS complex, the current is going towards lead 1. If we have towards FEF as well, so the axis must lie between 0 degree and 90 degree. So the axis is normal. Technically, we don't have to define that it is 65 degree or 70 degree. We can always say it's normal axis or right axis or left axis. Now, how do we define left axis? Now consider the second row. There is a positive QR complex in lead 1, but what about FEF? We get a negative complex. So the current is towards lead 1, but it's away from FEF, upwards. So the axis must lie between 0 degree and 90 degree. So this is left. The axis is going towards left. It's left axis rotation. Now, what about right axis? We get a negative complex in lead 1. The current is going away from lead 1 on the right side, and it's obviously going towards FEF. It's positive in there. If you look at this, so the axis must lie between plus 90 degree and plus 180 degree. It's right axis deviation. But if we get both lead 1 and FEF negative, the current is going away from the right lead 1 towards the right side, is going away from the FEF upwards. So the axis between minus 90 degree and minus 180 degree. It's superior axis in the no man's zone. So after that, we should look at the waveforms. The P waves, are they too wide, too tall, or look funny? That is, are they ectopic? The QS complexes, are they very high, very tall? Is there any pathology Q waves? Is there a bundle branch block pattern or a particular notch in there? Then look at the ST segments. Is there any elevation or depression? What type of elevation is there? What type of depression is there? We will be having lecture individually about these waves later on. So this is just an overview. Then we look at the T waves. Is it inverted? It is flattened. Is it too high? Is too tall? What about the E waves? If it is there, why it is there? Why it is so prominent? So this is the waveform description we'll be giving. Now, a little bit about P wave. It represents the contraction of the atria. And we should remember, it should be usually upright in lead 1 and 2 and FEF, and also upright in V26. And it should be inverted in FEF. That's the characteristic of a normal P wave, 2.5 by 2.5. That's the dimension. Amplitude should not be more than 2.5 millimeter, and the duration should not be 2.5 boxes. Look at this one. A beautiful, the P wave, upright in lead 1, 2, FEF. It's uptrend V2 to V6. So it's a normal P wave. It's a normal sinus rhythm. The R wave, it represents the contraction of the ventricles. Now, the R wave, actually we have said, it represents the QRS complexes, the ventricular depolarization. And the height of the R wave only depends, it signifies the amount of current generated. That means the more muscle mass, the more is the current generated, the more should be the height of the R waves. So R wave varies depending on the ventricular wall thickness. If there is not a too thick obesity or very thick chest wall or pericardial effusion or pleural effusion or something like that, R wave height will signify that the ventricular wall thickness is normal or abnormal. Sometimes it may be misleading, but most of the time it gives true information. Now, V1 to V3 measures of RP, thinner walls. They are a smaller R wave because the current is going towards the left ventricle, the heaviest one. Most of the current is going away from there. So there should be a small R wave in there. V4 to V6 mostly measures of the left ventricle. So the R wave in there should be larger because they are recording the current that's going towards the left, that's going towards them. And the left ventricle is on the left. So the R waves in V4 to V6 should be larger. Normally, that's what we get. And therefore, the R wave increases in amplitude from V1 to V6. Look at this one. Small R wave in V1, gradually improving inside. Most of the time, it's the V5 which records the largest R wave. And sometimes it may be the V6, but most of the time it's the V5 which gets the largest R wave. The T wave, we look at the T wave morphology and also the amplitude, and we also look at the intervals, as I have mentioned. We'll be talking about these intervals and the T waves and ST segment in different lectures. Now, during, I have told you that you have to also see whether the ECG you are seeing, is there any interference in that that can distract you from proper interpretation. Look at this one, muscle tremor. So how can I get rid of this problem? Here, electrical interference is caused by the patient's tensed muscle. Re-prepare the skin. Ensure that the patient is relaxed and perfectly still. If it's Parkinson's disease, you cannot help too much. And also ensure there's no lead fracture or the lead screw is not loose. And this is sometimes we see the baseline is going away. This can happen if the patient is taking a deep sighing respiration or moves. Again, prepare the patient. Tell them to relax and make sure the electrode area is dry. And make the patient at ease, put the patient at ease, make him or her comfortable. And if necessary, make the patient propped up. That will be helpful. And this is always have a look at the ECG. Always have a look at the lead one. Look at the P wave, because this is very common and very commonly misdiagnosed by general physicians. So I have put this ECG before, I'm putting it here again because it's a commonly encountered problem. So right and left transposition is a problem that we can encounter, we should be aware of it. So this is an overview. What I'm trying to say that ECG is the heart of cardiology. It's fun, educative, but ECG can be mysterious. And systematic approach is the key to success. Books, discussions, a lecture like this, all can help only to a certain level. But it's your personal habit of going through lots and lots of ECG, looking at it repeatedly, that is the most helpful thing in getting acquainted with all the mysteries of ECG, all the funs that can be associated with ECG. And you can be a master on yourself. And all the masters will say, I am still having to learn many things of ECG. For myself, I can only say, I'm just a beginner because there are so many things to learn about ECG. and so much fun in there. The more you go in depth, the more fun you will get. And I hope the audience will be having some fun and will be interested to go through the next level lectures that we will be imparting in each week. And you can actually have some grips on ECG and have fun with ECG. Thank you, everybody.
Thank you, sir. Thank you for your brilliant lecture and presentation. I request our Honorable Rafiq Ahmed sir to make a comment on this. Rafiq sir.
Thank you. Well, Odud is the master storyteller. So he's done a great job as always. Can you hear me?
Yes, sir.
Yeah.
Yes, sir.
Great job. And I think these are the things that, you see, we study, Odud studies, Atahar, all of us study. And so listening to this talk was enlightening, but please remember it when you interpret the EKGs. That's important. I always tell people in medicine, if something does not add up, it puzzles me. And then we try to find a solution. It can be a clinical scenario. Somebody comes to me with impaired vision, and I just don't take it, well, it's an eye problem. In medicine, we have to think a little bit more. Is the brain involved? Is there something else? Something is not adding up. So likewise in ECG, we keep looking at it, and every time we find an abnormality, it's not always a good idea to be satisfied with obvious correct answer. We have to look beyond that. Is this really an old anterior myocardial infarction, or is it because the lead was misplaced? Is it Brugada syndrome, or were the leads placed too high or too low? Those are the important things that we have to look at. And thank you for such a nice talk. Thank you.
Athar bhai.
Athar bhai, please unmute yourself. Okay.
Can you hear me?
Yes.
Yeah.
What I want to say about to our participants, that you just see this man. This is Professor Abdul Wadud Choudhury. He is a renowned teacher. He is the master, and he is the master of teachers and master of classes. Really, it is a wonderful lecture. Actually, we wanted this. I don't know whether our participants are actually really happy or not, and I will request our participants to make comments in their chat box what they want, whether they're happy or not. But I am really happy. I have still now, this is the lecture that is the every day. I am still, but I learned many things from this today's lecture. So this is a wonderful, brilliant lecture. I think our participants will be happy and will learn many things from this lecture. This is the lecture what we actually wanted to deliver to our participants. So thank you, Professor Wadud bhai, again. Tushar.
Sir. Sir, before going on to I want to make a Wadud sir, there is a question for you.
Yeah.
The question is from Dr. Sudhir. He questions is why in the States V1 is taken as the rhythm lead, whereas in the kingdom it's lead 2, which is taken as rhythm lead.
It doesn't matter. Now look at this one. We have said the lead towards which the current is going will record the highest deflection. Now look at V1. V1 is just in the fourth intercostal space over the atrium. And the heart, two-thirds to the right, left, one-third to the right. The atria in there. So any lead just placed over there will record the electrical activity quite nicely. Again, look at lead 2. The SA node is situated near the angle of Lewis on the right side. AP node a little bit down on and inferiorly to the left. The current from AP node goes through the interventricular septum, through the apex is going up and deploys the whole ventricle. Now, the whole of the atrial depolarization is the current is going from SA node to AP node after deploying the atria. The axis is towards the lead 2. So you can always take either lead 2 or V1 as a rhythm stream. But remember that in a very lean and thin person, sometimes we get better looking P waves in AVF. You can do that. And sometimes in a very obese person, the diaphragm is much elevated and the heart is horizontal. Sometimes we can get a very beautiful looking P wave in AVL or lead 1. So that may be taken as a rhythm stream. The most important thing, which lead record the best looking P waves, mostly is lead 2 and V1. Now, US and UK, it doesn't matter. As someone is saying that America and USA and UK, they are divided by the same language, English. They speak the same language in different way. It doesn't matter. One is goes on the right side of the road, one goes on the left side of the road. It's their way of thinking. But both of them are correct.
Sir, regarding this issue, I want to ask Rafiq sir, is V1 taking V1 gives us more information than taking lead 2, especially the RBB and LBB, which cannot be understood from lead 2, which is more evident on V1.
No, for bundle branch block, I think.
Rafiq sir.
Yes, for bundle branch block, it's very lead V1 is very important, and I look at lead V1 and V6. So if you see lead V1, you see an RSR pattern, and in V6 you see a terminal S wave. And same, the reverse is for left bundle. In V1 you see a small R wave with a deep S wave, and in V6 you see a wide R wave. So I mean, and for left bundle, sometimes I will use lead 1 and also, but mainly V1 and V6.
Tushar, whenever we're talking about P wave, we look at lead 2 and V1. When I look talking about QS complexes, and especially bundle branch block, we always look at V1. That's a separate issue. Looking at P wave, looking at QS complexes, as Sar was saying.
Hello,
yes, sir.
Tushar. Just to remind you that there will be a session of Profik sir, there is ECG session, but there is an interesting question in the chat box that I want to know from the Professor Wadud. Wadud bhai, there is an interesting question in the chat box, and to you and also Profik sir. Sir, is there any possibility of irregular RR interval in complete heart block? If it is, how?
Yeah.
There is a question in the chat box.
Yeah, it's possible. Sir, will you answer it? Sir is master of that.
Yes. Well, in complete heart block with sinus P wave, majority of the time it is regular. However, if the escape rhythm is unstable, I mean, I have seen cases where there is extremely slow ventricular rate of like 25, 26, and you can see some degree of irregularity. But that is clearly evident because if there is P wave, you will run into problem if the patient has underlying atrial fibrillation.
Yes.
And very slow ventricular response versus complete heart block. That we cannot differentiate in the setting of AFib. Otherwise, if the P wave is marching through, it's complete heart block. But it is rare.
Another interesting question, Madhu bhai. Hello.
Hey,
Whether the patient is supine or standing, does it matter for ECG? This is the question.
To some extent, not much. One thing is that Eindhoven first identified that when you put a lead 15 centimeter from the heart, when the lead as near the heart will record a greater degree of amplitude. But if it is away, the degree of deflection, the height of the amplitude of the deflection will be gradually lessened. But after 15 centimeter, 15 centimeter pore, it doesn't matter. That's why you can, beyond 15 centimeter, you put a lead at 20 centimeter, 30 centimeter, or 80 centimeter, it doesn't matter. Einthoven made the leads very away from the heart on the right arm, left arm, and on the legs because of that reason. So standing and supine too much doesn't matter. But remember that your diaphragm is lowered down. So there, the heart is now, it was like this. When the diaphragm is lower, the heart becomes more vertical, a little bit more vertical. So the ventricular surfaces, your lead are placed in a fixed position. The heart is moving a little bit away and down below. So the amplitude of the R wave in the precordial leads may be a little bit changed. Rafik sir.
Well, I think that position-wise, the limb leads doesn't matter at all, as what they pointed. But if you look at the chest lead, we put in lead, it will drop probably by 1 intercostal space, the heart position. So that may make a difference.
Yeah.
But this is an unusual circumstance because except during treadmill stress test, we are not going to do EKG. Other thing, we cannot compare ECG if they're in different position.
Exactly, sir.
Because if
Always,
somebody, if I do an ECG in supine position and the next comparison is in standing position, I don't think it's a good idea to compare this ECG.
We have to have a standardized condition. That's why always you do it in supine condition. You can just prop up a bit, it doesn't matter. But that's it.
Tushar, hello. I think the discussion will be endless if we discuss the question, that is a question from the audience. But there is a ECG session of Rafik sir. I think we should start it. Right.
Yes, sir.
I'm waiting for it.
So, shall we start that?
Yes, sir. Yes, sir.
Yes, sir.
So I have some questions that we're going to discuss. And we have choices. And so I would like the audience to answer questions. And remember, as we discussed, that there are only answers and we can discuss those. So this is the first ECG. And please look at it. Please decide on it. I could not put the question and the answer on the same slide. So these are the choices. And I'm going to go back to the ECG again. And what is the diagnosis?
Sir, participants are requested to answer to the chat box, sir. Dear participants, you can answer. That is 1, 2, 3. Either of the answer you can put in the chat box.
1, 2, 3, 4.
I'm going to go back to the ECG again. This is the ECG. And these are the choices. And once everybody finish answer, then we can, please let me know, Athar.
Yes, sir. So Tushar, you can take the time that is 1 minute or 2 minutes like this, Tushar.
Sir, we should give 1 minute for this ECG. I guess.
1 minute. There is more than 200 participants.
Okay.
Yes, sir. Yes, sir.
We can.
So how can we?
Sir, today we are developing a system so that we can see how many 1, how many 2, but not today, sir. Today today we'll just see the chat box and we can see what are the actually
overall assessment we can take.
But it needs a technique, sir, so that they are developing this technique so that next classes we can say how many percentage of the 1 or 2 or 3 like this, sir.
Sure. But will you be able to tell me which is the maximum answer?
Sir, from the screen we can continuously see, sir. Some are putting 4, some are 3, some are 2.
Okay.
Number 1.
Oh, okay, from each person.
Yes, sir. Each person, sir, yes. We can see the answer, running answer,
We cannot get the total collections, sir.
Yes.
We
No, no.
Okay,
didn't
good,
have the
good.
system
But
put in there.
we can see the answer, sir, running answer. SBT is common, sir. SBT is the common answer.
Okay, good.
SBT. SBT, sir. Sir, I am checking the chat box and most of the common answer
Okay.
is the SBT, sir.
So we'll go to the ECG then. So this is the ECG, and we can see that SBT is the commonest answer. I mean, so but this ECG does not make sense. I mean, that's what I'm talking about. That look at this. I mean, signals are there, and there are signals here. There are signals here. There are signals here. There are signals here. So clearly, I mean, suddenly we look at it, looks like SVT. But as I told, that it doesn't make too much of a sense in this ECG. And
Sir,
if we look at this,
sir, can I interfere, sir?
yeah.
Sir, before going detail, can I ask Wadud bhai, is there any technical error? Is the ECG technically okay?
That's what sir is saying. Look at this one. I don't know, below the 81105, look at this, the mark in there. What is this mark superimposed on a QRS complex? Is it an artifact? And look at the near the end. There are some marks in there. That doesn't add up actually. A heart is not that chaotic. And if it is chaotic that much, it should not have such narrow complex chaos. It should have a wide complex chaos, a VF, but it's not that. So it doesn't make sense. Sir.
There are also some Bezier signals also.
Yeah.
Yes. So this is actually a rhythm strip. And so look at the same patient. So I've now added others. So clearly look at this here, that there is sinus. This is a telemetry monitor, and then each patient ends up with artifact.
Yes.
But the artifact is fairly regular, and it looks like. So please remember this, that we can see artifacts, especially in telemetry. Now, luckily, this is a narrow complex irregularity, and nobody is going to go and jump and shock the patient.
Yeah.
But how about this one? And I'm going to go and show you the answer and then go back to this ECG again. So these are the choices.
The obvious answer becomes ventricular tachycardia. Looking
Dear
at
participant,
that
please
initially.
answer. VT.
Everybody will be saying that.
VT. We can see the answer, sir, running answer.
So everybody is VT, right?
VF also, 6 and a symptom also, VF1.
Someone said 1.
Dear participant, we cannot see, we can answer randomly, no problem.
It doesn't
But
matter.
then names are coming sometimes.
You know, sir, I always tell my students, make an S of yourself in the class so that you become a hero during the exam.
I
Tushar,
also tell
time.
them that make mistake in the class, but not in the examination hall.
Sure. So, I mean, I think we can discuss this, right? Any of the panelists have any comment on this ECG, please?
Sir, on the ECG, please.
Sir,
go back to
it
the
looks
ECG.
like it's a sinus rhythm with a lot of artifacts.
Sir, go back to the ECG.
Okay, I'll go back to the ECG.
Is there Dr. Firoz is here? Dr. Firoz?
Yeah, Dr. Jamil.
Sir,
Yes.
It's
Yes,
a sinus
yes,
rhythm
sir.
with artifacts.
Sinus
Sir,
rhythm with
if
artifact.
we look at the strip in the 4th, 5th level, there is clear-cut QRS complex, which stands
narrow complex.
what artifacts and QRS complexes are defined.
This is
In the
where my
first and
arrow
second
is, right?
Yes, sir. Yes, sir.
Arrow is.
Okay.
It
Perfect.
may be confused in the first and second, but in the
Yes.
3rd and 4th and 5th ECG, it is clear that there are artifacts.
Sir,
It's
yes, Manoj.
all the list showing the same organized wave in here.
Yeah.
Yes. So no question. I mean, I'm going to add. So if we look at the first two, it's very difficult to say what it is. But
Yeah.
what is very important, before you do anything to this patient, please go and ask the patient if he's awake.
Professor is here.
Yes, sir. Yes, sir.
Yes.
Full of artifacts, sir. Full of artifacts.
Yeah. So if
God
this
bless
is
you.
VT and VF, it is very unlikely that this patient will be awake.
Yeah.
Yes, sir.
So that's important. And please remember, in my life, I have seen patients being shocked for this rhythm. And the clue is here, as mentioned, that there is something there. And if I put a caliper, it marches through. So that's important. And if I, yes, so this is the ECG, and look at the top rhythm. Same, these are simultaneous. This lead is very, very clear. It's not made later. If you look at, go down from this one, if you go straight line down, and you can see where we mentioned that there is something there.
Yes.
So this is important. And this is clinically very important. It will prevent you from shocking a patient. And also plus, but please remember to, okay, so we'll do another one. So this Dr. Wadud Chaudhary really described very, very clearly. And this is the ECG.
Dear participant, please.
And then I'm going to give you the choices. Normal ECG, left atrial rhythm, right arm, left arm reversal, or chest lead misplacement.
We have Dr. Monor with us. Dr. Monor, can you hear us?
Sir,
Yes, sir.
Sir,
What?
ECG, please, again.
Yes,
Go
sir.
back
Yes,
to the
sir.
ECG.
Yes.
Okay,
Yes,
I'll
sir.
go to the ECG.
ECG.
Yes, sir.
It's a beautiful one.
Number 3, Lipi Devnath.
3 is most answer.
Sir, again, go to the answers.
Sir.
The student have the chance of answering.
Yes.
Sir, I will request Dr. Monor to comment first, sir. Dr.
Yes.
Monor
Sir,
is with us, sir.
I think if we go back to the ECG and look at the ECG carefully,
Yes.
at the morphology of the lead 1 and lead AVR, lead AVL, in case of lead AVR, the P wave is upright. And in case of lead AVL, the P wave is inverted. But if we look at the chest leads, there is normal progression of the R wave. So most probably this is due to abnormal replacement of the leads.
And which lead?
Limb lead reversal, sir.
Yeah, so probably left arm, right arm reversal.
Yes,
Left
sir.
arm, right
Yes,
arm reversal.
Yeah.
Left arm, right arm.
We
One
call
of the-
technical dextrocardia.
Yeah, one of the things that we do is we write on the report, suspect arm lead reversal. But the key is what Dr. Manwar mentioned, that the P wave morphology.
Yes.
Because if this was not reversal, then it is a lateral myocardial infarction. Because there is a big, but the P wave is inverted. But what we do, we always say, suspect arm lead reversal, interpretation does not assume reversal. And then you interpret suspect lateral myocardial. But I think this is very, very clear because of the P wave morphology. So majority answered. Any alternate answer?
Sir, whether technical dextrocardia is a acceptable term, sir?
I do not use that because then you are assuming dextrocardia. I don't think I'll use that term. I'll just say limb lead reversal, chest lead reversal. What do any comment on that?
Sir, this is a common problem. That's why I was paying attention to it much. In my experience, around at least 5% of the outdoor ECG, there is some mistake like this. And also, if we have an extensive period on diagnostic errors due to misplaced leads. We'll also show there are various forms of limb lead displacement and different sorts of abnormality that we can see in the ECG. And most common is like this: whenever things do not add up, we should ask for repeat ECG.
Okay, so this is the same patient, October 7th, and another ECG in January. If you see, lead 1 and AVL totally different. No other lead have changed.
Yes.
The next one. So this is the ECG.
Please, আমি ওই যে ক্লাসের মধ্যে আমেরিকার ইয়ের সাথে হচ্ছে এটা ক্লাসের মধ্যে
So I'm going to go to the choices. Please read the ECG in your mind, and then I'm going to show you the choice. These are the choices.
One thing I'm telling the participant, look at this. Sir is always telling what is the rhythm. Before the basic diagnosis, we do not pay that much attention. We say this is MI, this is so, this is nice, but we do not say whether the patient is in sinus rhythm or not. But from an EP specialist, this is very important. Is the patient in normal sinus rhythm? Then we go into other things. What other problems the patient may have had?
Can I comment, sir?
Yes.
Yes, sir.
Sinus rhythm and pericarditis. POF is normal in inferior lead and also looks like ST elevation not classical, concave upward, looks like early repolarization pattern in all the leads. For that reason, global change. For that reason, pericarditis most likely with sinus rhythm.
Okay.
But there are some points in favor of the early repolarization, Govindu.
Yes, I think it's a point is a R wave meeting point on the R and ST segment. That means J point is to some extent elevated, seems to be. For that reason, I mentioned early repolarization.
Points against pericardial effusion is
pericarditis.
Pericardial effusion is pericarditis. In pericarditis, usually most of the lead has this type of elevation with concavity upwards, except AVR where it is depressed, and more conspicuous at the apical leads, like V5 and V6, where it is looks like normal. So these are the
look at lead V4. Look at lead V4.
What is V4?
Cannot be explained by this.
I think Dr. Firoz will also participate, but before that, I want to comment. In case of the pericarditis, there should be tachycardia, and the PR should be depressed in AVR, but I am not seeing it.
Yes.
Yes, sir. I think these features are not present here, so this is not consistent with acute pericarditis. Rather, we should pay attention to lead V4. Morphology of the lead V4 cannot be explained by this normal way. This can be abnormal positioning of the chest lead.
Chest leads.
Yeah.
Yes, sir. But the regarding the ST elevation in inferior leads, we should also go for the history of the patient and biochemical investigations and follow-up ECG also. Definitely V4 is a misplaced one.
Is it just because the
it is not a pericarditis? It is not pericarditis as the rate is low and the changes in AVR is not there. There is no change in the chest lead in the sleeve segment.
You are pointing towards coronary. Is it because that is the narrow Q in 2-3 AVF, Firoz?
No, sir. Regarding the ST position, the ST in the lead 3 and AVF is a bit elevated. So if the patient has got chest pain, we can go for this follow-up ECG and cardiac biomarkers.
Okay.
Yes, ST elevation more in 3 and AVF inferior lead, but other leads not so significant.
Yeah. So, I mean, I have question. What do this the master of ST segment? What do
Sir,
there are some J points in the pectoral lead. J waves in pectoral leads.
What I'm worried about is the ST depression in AVL. Now, AVL is looking on the opposite to the lead 2-3 surface. Now, why there is ST depression in there? And if you consider the before, if the leads are properly placed, is there something wrong in the apico-inferior region? That will be the answer I will be asking, looking for.
So I think thinking about it, the comment was that possibly the lead V4 is misplaced. And I think in favor of that, if you look at the P wave in this V4, looks like positive followed by negative, which we see in lead V1.
Yes.
So my thinking was somebody put the V1 in V4 position. That's one. And of course, this patient came with chest pain. And this ECG time was 10:12 a.m. in the morning. And this is the next ECG. This was done at 2:28 p.m. same day. The ST segment has resolved. So this patient actually had inferior MI. And then if you look at this, have totally changed. It's because the lead was misplaced. So it was lead. Please remember, we always think of lead misplacement as limb leads, but chest leads can also be misplaced. Sometimes people will show, okay. So next one, we'll move on to this. This is the final one. The tricky part is that if right arm, left arm gets reversed, but then the limb lead and the leg lead gets reversed, that can be very tricky. I have a algorithm. I mean, it's very complex. I can send it to Atahar and then share with everybody else. So this is the ECG, and then these are my choices of.
Can I comment, sir?
Yes.
Again, ECG, please, sir. Just few seconds.
Yes.
Just 2 seconds.
Yes.
Atrial fibrillation, old MI inferior, and limb lead reversal, and atrial fibrillation.
But look at the rhythm strip, Govinda.
There are P waves, Govinda.
There are P waves.
Fibrillation.
Atrial fibrillation.
But there is atrial
fibrillation.
What about the chest leads?
There are P waves before the QRS complex. Each one.
Reversal.
The premature beats as well. Similar.
Reverse progression. Chest lead reverse progression.
Reverse progression.
Let us see the options now.
More complex.
Options are this.
Chest lead total reversal, arm lead reversal. So there are a good number of participants in favor of number 4.
Okay.
Because they are in a session of limb lead reversal.
Sir, can I put a comment in there?
Yes.
Sir.
Actually, this type of ECG actually shows why the background information should be accompanying the ECG. Because only then you can put a meaningful answer to the puzzle put to you.
Absolutely right. Absolutely. I think the history is important. So if we look at it, I mean, this one, it's very difficult to see the P wave like the last one, but you can see the P probably is negative in lead 1, and it's inverted.
1 and AVL.
Yeah, and then there is a QS pattern in 2 and AVF, and of course, this one. What doesn't add up? Not this. This is lateral MI, but this is not a V1 ECG. Right?
Yeah.
Yes.
So and the other thing that's happening is this looks like V3, but this doesn't look like V2. Very unlikely. So that was my initial problem. And of course, Dr. Govinda said atrial fibrillation, there is always a choice of that, but there is a P wave before. There is some irregularity of the RR interval, and of course, supraventricular premature bit makes it irregular. And then, of course, we can see P wave clearly. So even during sinus rhythm, sometimes because of extreme sinus arrhythmia along with PAC, you can see the irregularity and can look like a PIP. So it's an entertainment. Of course, if you look at this lead, you can't see the P wave, and that makes it more confusing, but we can see it here. So let's look at
Sir.
what are the answers? Yeah, go ahead.
No, sir. No, sir. Just before the answer, if this patient has the really lateral MI, sir. Now, if the patient, if we consider the lateral MI, so why there is no posterior MI for the why?
Yeah, posterior lateral MI. That is possibility.
I want to take participate mono and Firoz.
Why not inferior MI, 3 and ABF? If you consider 3 and ABF like B5, B6, why not
look at AVR, please. Look at AVR, please. Morphology of the QRS complex is AVR and POA.
And also lead 3.
And also lead 3.
Inferior MI without P wave in lead 3 is unusual.
So there is certainly reversal of the leads, and at the same time sinus rhythm. And in the chest lead, there are definite Q waves in V4, V5, V6, and prominent R in V1. So I think this may be a case of even true dextrocardia with MI.
Exactly.
I agree with
sinus rhythm. Why sinus rhythm? What's
it's sinus rhythm?
P wave.
Because each beat has got a definite P wave except one supraventricular beat in the rhythm strip.
QPSC.
The one before the last one.
Right.
That's the supraventricular.
And V1.
Dr. Momen, sir. We have got Dr. Momen with us. He wants to comment. Momen, please.
Sure.
Dr. Momen, can you hear us? Abdul Momen, Tushar.
Momen ke dao na.
Momen ke unmute karo. Dr. Momen, Abdul Momen.
Sir, we're doing.
Achha. Possibly he is muted.
He's not here. No.
No. He put a comment in the chat box. He wants to make comment. So, Momen, can you hear?
This is the.
Firoz.
Probably he's not in the faculty list. That's the problem.
Okay. So this is
Nick.
This ECG is
Moment ke chuka hai
January 27 at 5:56 a.m. and after 5 minutes, same patient. So the time 5:26 and 5:31. So it's about 5 minutes later, same patient. So you can see that lead V1, V2, V3, totally, the chest leads were totally reversed. And then there was limb lead reversed. And there is this interesting, look at this, now it has changed. I think there is also some reversal of right and left leg lead.
Yes.
And that can explain this a little bit. And as Monowar pointed out, lead AVR has changed totally. So this was limb lead with Chetty. I mean, you think about this thing cannot happen. Look at this is a real patient. And this is an American ECG. It's not the, so it's not the question of America, Bangladesh or anything. It's just that we make mistakes. And the other part is that a lot of times physicians are not doing it. A lot of times there are technicians and nurses, and they are doing all kind of ECGs, put chest leads in funny locations. So I think this is something that we need to keep in mind. I think we are done here. Thank you. And I think this is a wonderful session. We'll continue. If this format is good, every time there will be a talk and we'll bring some ECGs and we'll discuss this.
Yes, sir. And again, I will request our, not only the participants, that is our, among the participants like the Monowar, Firoz, Momen, we have got
our faculties,
that will increase our discussion, sir. We always invite them to participate.
Achha, there is Nozrul Bhai in the meeting.
আমি স্যারকে খুঁজতেছিলাম স্যার স্যারকে এখন দেখতেছি না কেন
Motion there.
মসিন কই মসিন আর স্যার দুইজন মসিন আছে মসিন আর
Any comment?
No, sir. Thank you very much, sir. Excellent session, sir. And next time we'll try to develop, that is the percentage of the patient, that is the choice equity, that is the among the options, that is.
I have a question, sir. I have a question. If am I permitted, sir?
Yes.
Okay.
Thank you, Rafiq Ahmed sir. Thank you,
Nozul sir is there.
Nozul sir. I have a question, just simple basic question. Isoelectric line, is it TP segment or PR segment? Simple basic.
Yes.
Sir, please, sir.
Yes. Isoelectric line, one of the important part that it must be a horizontal ECG. Like if the baseline is moving, then it becomes, and the TP segment, because if you look at pericarditis,
Yes, sir.
we cannot use the PR. The TP is our reference point.
Yes.
Where it is that, but the key is that the baseline must be in a horizontal. Otherwise, it becomes totally useless.
Yes, sir. Some of our participants already know that they have correctly told that is like you said.
This is TP segment. Yeah, yeah.
Thanks, participants. Sir, actually, আমরা কিন্তু নজরুল স্যারকে
নজরুল
দেখতে
স্যার
পাইনি।
আসছেন।
স্যারকে
নজরুল
স্ক্রিনে
স্যার
দেখতে
আসছেন।
পাইনি।
নজরুল স্যারকে দেখতে পাচ্ছি।
এবং মহসিনকেও দেখতে
স্যার
পাচ্ছি।
একটু আনমিউট করবেন? নজরুল স্যার আনমিউট করবেন? স্যার আসছেন। স্যার।
তো স্যারকে আনমিউট করে দাও।
নজরুল স্যার আসছেন।
Thank you. Actually, in fact, actually, I've started very late. I didn't know earlier, so I'm late for your program anyway. So as far as I heard something from Madhu and also from Rafiq, it is a pretty good discussion. And the last point, the question asked by Govind, I think that was TP possibly it should be the reference line or the isoelectric line for all purposes. And actually, since I have not attended throughout, possibly I cannot comment properly. But if any discussion point I can ask, I can join now. Yes. So how are you, Rafiq?
I'm doing fine, very well. Thank you, Nozul.
অনেকদিন পরে তোমার সঙ্গে দেখা হলো আর কি।
Homebound, mainly homebound. We have started working back. But again, this is not a forum. But please remember, when I first came to America in 1991, that was the peak of HIV. Even to this day, we consider every patient as HIV. Whether you are in a COVID hospital, non-COVID hospital, in a private practice office, or your friend, please consider everybody as COVID positive. And please take necessary precaution. Bangladesh physician community has a high rate of COVID infection. I pray that all of you remain safe and please maintain that thing. I think Nozul Bhai and we go back a little bit more. We had more infectious disease in Bangladesh. We were more careful before. Younger generation have not seen that many infectious disease. So please take care of yourself and
thank you.
keep safe.
আতার ভাই আমি দুটো প্রশ্নের একটু উত্তর দিতে চাই। একটা one question is that Dr. Shoaib has asked if the person has amputated limbs, either any leg or both, how to do this ECG. It doesn't matter. You put the lead anywhere near the stump on the torso. If it is more than 50 centimeters away from the heart, that Eindhoven triangle ensures that you can record the same sort of ECG, same morphology. Another question is that the inferior surface of the heart is formed by 2/3 by left ventricle, 1/3 by right ventricle, but inferior MI indicates RCA obstruction. Mind it, we are talking about RCA territory. RCA and LAT, remember that LAT supplies the left ventricle and anterior 2/3 of the interventricular septum. Now, interventricular septum serves both the left ventricle and right ventricle, isn't it? Mostly to the left ventricle. Again, RCA supplies the inferior surface. Inferior surface doesn't mean it's right ventricle. It means the inferior surface of the heart. So RCA supplies right ventricle as well as the left ventricle. And that's why inferior MI, and when we talk about the surface of the heart from the ECG point of view, we talk about the territory of the artery that is involved. That may be left ventricle, that may be right ventricle, depending upon which surface is involved.
Although can I add something?
Sir, of course.
Actually, I think you have mentioned already in your presentation. There are two important aspects. One aspect is the wave and the segments and the complexes. How to measure where the segment starts, where the segment ends, where the complex starts and where the complex ends. and that should be specifically to should be taught to this to younger fellows. Number one. Number two is we must correlate this electrical phenomenon with the mechanical phenomena or hemodynamic phenomena of the heart. That is very important because in many of the in imaging studies, this is very important nowadays because ECG is a gross reference for almost all imaging studies for cardiovascular aspect of this thing. So two aspects. One is the point from where to where the complexes and the segments and the intervals starts and ends. That is important. Another important is the correlation between the electrical activities and the mechanical activities of the heart. These 2 points, I think I have already emphasized in your presentation.
So there is a question by Dr. Sudhir. I want to mention this. He asked, are depolarization and contraction means the same thing? If not, what is the difference? So it's different thing. Now, after depolarization happens first, and after the depolarization, the contraction begins.
Exactly. So thank you, Jamil.
Someone has asked one important question. What is Lewis lead? Some person has asked.
Yes, Manohar, you are the person.
Actually, Professor Salam sir asked this question.
Yeah.
Salam sir.
Manohar bolbo na ami bolbo?
Sir, choice is upon you.
No, Manohar bolo.
Tell it. Manohar, tell it.
Manohar bolo.
I can also tell, but
Lewis lead some modification of the available leads. This is deliberately made to make the atrial activity prominent. That is the P waves prominent. And for this reason, the right arm lead is placed to the right second intercostal space near the sternum, and the left arm lead is placed near the right fourth intercostal space near the sternum, and the left lower limb lead is placed near the inferior margin of the right chest case. That is the right lower rib, chest rib, chest margin. By this modification, the atrial activity becomes prominent, and we can make atrial flutter clear, or we can make the features of AV dissociation in case of ventricular tachycardia prominent.
Thank you, Manohar, for your excellent. Do you want to add something, Wadud bhai?
Actually, exactly. Lewis lead is actually for seeing the atrial activity properly. But also, if you do not have the chance of doing the Lewis lead, you just increase the sensitivity, make it 1 millifolicle to 20 millimeter. So the atrial activity gets bigger. Then you get a picture where you can see the atrial activity better. There's an easier way of doing things.
Yes.
Tushar, we are, Dr. Firoz, you want to make comment, I think.
Sir. In fact, I want to make two suggestions. Number one, in different literature and textbook, we used to see the duration of different waves in the form of milliseconds. So my request to the younger fellows and students that try to express durations in form of milliseconds. That will make it easier to understand the text and other things. Another important thing regarding the placement of limb leads. Usually we use different clamps, 4 clamps in 4 limbs. If we cannot place these clamps, you can use the knobs with the cable and can put it in any place in the limb or near the junction of the limb with the trunk.
Yeah.
These are the two important things.
Tushar. Hello, Tushar.
Adharali sir, can I ask another question, sir? If any...
please. Govindo, before your question, just I want to make a comment. Tushar, can you hear me?
Yes, sir.
No, Dr. Tushar, hello, Tushar. Hello, Wadud bhai.
Unmute.
Tushar, out of form. Yes.
Tushar,
should we?
No, Tushar, just before your conclusion, just I want to announce one thing, that is, I request our participants to follow all the lectures. That is one lecture in a week. If you miss one lecture, there will be some problem in your. So our lectures are designed in such a way that if one follows all the lectures, there are 20 lectures, they will be able to discuss, understand everything. There is a So it is better to follow all the lecture. This is a request to our participant. And Tushar, আমাদের আগামী রোববারের প্রোগ্রাম সম্পর্কে বলো আর গোবিন্দ কি বলতে
And the lectures are available in the Facebook, isn't it? We'll be making them available in the Facebook.
Yes, sir. Sir, this is Rihu. The lectures are available in the Facebook, sir, as videos. They can get the participants can get the videos.
Okay.
ECG Study Group, Facebook.
Yes, sir. In the Facebook page of ECG Study Group.
Yes, what we want to we tried that stepwise understanding of the ECG, which is very important. So we started with the basics from physiology, anatomy, physiology. Now this is the ECG understanding of history, machine, paper. And the next class will be on ECG interpretation, that is components of the ECG interpretation that includes components, rhythm and triangle, rate, rhythm and axis. And if we follow our lecture today, it is already much of the things have been, many of the things have been discussed today. And this will help you understand the next lecture. And the next lecture class will again be taken by Professor Shahabuddin Ahmed sir. And hopefully all the participants and the panelists will be present there, and together all we can make a very interactive and well understandable ECG class.
So again,
So,
10 p.m.
Again,
Next Sunday, 10 p.m. Again.
10 p.m. Will
Yes.
that be good?
Next Sunday again, 10 p.m.
10 p.m. All right.
and participants, the time might be.
Tushar could not hear you. Tushar could not hear you.
With other, sir.
And now.
Oh,
We
okay.
could not.
So this avoid clash with other webinars. So we can put our intense concentration in this program. So next lecture on next Sunday at 10 p.m. Hopefully all can attend.
Rafiq sir, we are really grateful to you. You are getting so
Yes,
much time
of
to
course.
us. And Yodul sir is there.
And yes, all the senior ones, all the senior teachers and everybody actively participated in this program, and that makes it a interactive session, real interactive session, I should say. Rafiq sir, for your concluding comments.
Thank you all for the participation. I think we'll continue doing this, and the key part is the more pictures we look at, the more we'll recognize. Just recognizing your friend. If you don't see their picture for 20, 30 years, you will not recognize that person. So please look at pictures. And the most important part is look at the normal ECG picture. If you can recognize normal ECG, then if something is not normal, it will stick to your eyes, and then you try to find an answer to that. Thank you.
Thank you, sir.
Always a pleasure.
Thank you, sir.
Thank you, everybody, and good night.
Good night, all right.
Good
Thank
night.
you.
Thank you, sir.
Assalamu alaikum.
Salam, sir.
Sound, sir.
Rafiq bhai, do you want to have? Yes.
Yes, sir. Sound, sir.
This to the audience, Akem Rafiq is representing Beximco, and they are really helping us to put on this show. And they are supporting us from the logistic support and all the technical support that's needed.
Thank you, sir.
Thank you so much, sir. Thank you.
Rafiq bhai, do you want to make a comment?
Thank you,
না
Ribu.
স্যার মানে এখানে কমেন্ট করা স্যার এটা আমার জন্য একটা প্রিভিলেজ তবে স্যার উই ফিল প্রাউড অফ দ্যাট এন্ড উই আর ভেরি মাচ গ্রেটফুল যে এখানে স্যার আপনাদের মতো লিজেন্ড কার্ডিওলজিস্ট স্যার আপনারা পার্টিসিপেট করছেন এবং আমরা এই ধরনের একটা প্রোগ্রামে আমরা সাপোর্ট দিতে পারে স্যার বেক্সিমকোর থেকে আমরা অল অফ আস ফ্রম বেক্সিমকো এসবিএম এন্ড বেক্সিমকো সেলস থেকে আমরা উই ফিল প্রাউড অফ এন্ড ডেফিনেটলি উইল বি উইথ ইউ ইন ফিউচার স্যার
Thank you.
Welcome, Rafi bhai.
Absolutely, sir.
Thank you, Atar bhai. Thank you.
so much.
Thank you, Rafi bhai. Thank you.